Welcome to another episode of Doctors in Court. Thank you so much for joining me. My name is Sabine Fonderson. I'm a general practitioner. The case of a stillbirth. Even when you do the right thing, mistakes can happen. And this one is a tough case. If you're a doctor, a midwife, or anyone who's ever been part of a pregnancy care, you'll feel this one in your gut. A baby was stillborn. The parents were devastated. The doctor followed the protocol, but they still ended up in front of a disciplinary board. Today, I'm walking you through a real case that asks one of the hardest questions in medicine. What do we do when we follow the guidelines and the outcome is still tragic? Let's go back to 2008. A 33-year-old woman of Pakistani descent, pregnant with her second child. She's got a BMI of 39 and gestational diabetes, and that's already a high-risk pregnancy. At 37 weeks, she sees her gynecologist. He checks her vitals. Ultrasound shows a 1-week growth delay. CTG, that's a fetal heart tracing, comes back normal. There's no dilation. The baby's head hasn't dropped. The plan, wait a week, check again. But a week later, there's no heartbeat, the baby's gone, stillborn, just like that. And the parents, they want answers. They file a complaint. They say that the doctor should have induced labor earlier or done a C-section. The waiting cost, that 1 week of waiting cost them their child. Let's pause here. There's a few things I want to unpack. First, gestational diabetes. It's not just about the sugar, it's about having bigger babies, immature lungs, and unpredictable outcomes. And that's why induction is recommended between 38 and 40 weeks and not before, unless something is really wrong. Second, the CTG. This test looks at the baby's heartbeat to check if they're in distress. In this case, it was normal. If it had been abnormal, this would have been a totally different episode, or maybe not even an episode. And then there's growth. A 1-week delay is not a red flag, especially not in a woman of non-Caucasian background. Different populations have different average birth weights, and that matters. Now let's go back to our doctor. He followed guidelines. He did an internal exam. He checked the CTG. He documented the plan. He even discussed induction, but the body wasn't ready yet. And still, the baby died. The parents weren't accusing the doctor of being cruel. They were grieving, and they were asking themselves, could you have done better? Could you have done more? They said that there was poor communication between the gynecologist and the internist, and the internist was the one managing the mother's diabetes, and they felt dismissed. And that's where things get blurry, not medically, but emotionally. Because even when everything is technically done right, emotions run deep, and grief wants accountability. So what did the disciplinary board say? First, let's bring the clinical findings that surfaced after the stillbirth. A pathological examination of the placenta was done, and the conclusion was that extensive regressive changes were seen, chorionitis, signs of ischemia, and retroplacental bleeding cannot be ruled out. An MRI of the abdomen and the baby's head was performed on September 13th of 2008, and no major developmental abnormalities were seen in the heart or the brain. Now, despite these findings, the disciplinary board emphasized that these post-mortem results did not change the fact that at the time of the consultation, there were no medical indications to induce labor. The CTG was normal, there was no cervical dilation, and the mother's vitals were stable. And the conclusion of the disciplinary board was crystal clear. It is deeply tragic what happened to the complainants, but the doctor did not act in violation of the professional standards expected of a gynecologist. The fact that, as he himself stated during the hearing, he could in future pregnancies err on the side of caution, and indeed did so in the complainant's subsequent pregnancy at another hospital, does not change the conclusion. The complaint was therefore declared unfounded and dismissed. Let's clarify some key medical terms. CTG, that's a cardiotocography. It checks the baby's heartbeat and movements. It's our window into fetal well-being, and in this case, it was normal. Ischemia, that's a lack of blood flow. The placenta showed some signs of this after the fact, but it wasn't obvious beforehand. And standard of care. This is the legal and ethical line we walk. Did the doctor act the way any reasonably competent colleague would have under similar circumstances? That is a test. I have 3 questions I want you to think about. If the outcome is tragic, but the care was technically right, should the doctor still be held accountable? It's one of the hardest things to reconcile in medicine. Emotionally, it feels like someone must be accountable. But professionally, we have to ask whether the care was safe. Was it reasonable? And did it align with current standards? If it was, as it was in this case, then accountability shifts from the individual to the system. And sometimes we need to acknowledge that medicine cannot always guarantee the outcome, only the effort. Do we need better ways to personalize care for patients who don't fit the average? Whether that's due to ethnicity, weight, or underlying health issues. Well, absolutely. Guidelines are designed for the average, but most patients are anything but. Ethnic variations in birth weight, gestational complications in patients with high BMI, or multimorbidity, these should all push us to interpret data with more nuance. Personalized care isn't a luxury, it's safer care. When do we as clinicians need to override guidelines and just say, I know the book says to wait, but my gut says act now? When your experience, your clinical instinct, or your patient's distress tell you something isn't right, even if the numbers say otherwise, guidelines guide, they don't replace judgment. If you're considering acting outside the protocol, document your reasoning, discuss it with a colleague, and make the decision together if possible, but never ignore your gut. That's really wisdom in disguise. Here's what I'm taking away from this case. First of all, guidelines are necessary, but they don't remove the need for judgment. Secondly, communication, especially across specialties. I do this often if I don't understand a patient's complaint, or if I feel like a patient is complaining for too long and I've tried everything and nothing works, I seek help from other specialties. It's a lifeline. And finally, being right doesn't mean that you're safe from complaints. Unfortunately, in medical practice, people will complain even if you've done the right thing. And the best protection we have is documentation, compassion, and reflection. Before I end, I want to tie this particular case back to the evidence. A recent large scale study published in Medicina in 2023 looked at over 50,000 pregnancies, including more than 2,000 with gestational diabetes. And their findings were that while gestational diabetes increases the risk of complications like preterm birth, macrosemia, and their findings were that while gestational diabetes increases the risk of complications like preterm birth, macrosomia, and NICU admission, and NICU means neonatal intensive care unit admission, it does not always. Before I end, let me tie this back to the evidence. A recent large-scale study published in Medicina 2023 looked at over 50,000 pregnancies, including more than 2,000 with gestational diabetes. The findings showed that while gestational diabetes is associated with things like preterm birth, macrosomia, oh, come on. Before I end, let me tie this back to some evidence. A recent large-scale study published in Medicina 2023 looked at over 50,000 pregnancies, including more than 2,000 with gestational diabetes. And their findings showed that while gestational diabetes increases the risk of complications like preterm birth, macrosomia, and NICU admission, it does not significantly raise the risk of stillbirth, not when managed properly in a multidisciplinary setting. The take-home message is this: gestational diabetes is complex, it requires monitoring, documentation, and often collaboration across specialties. The system works well when it's designed to do so. Unfortunately, in this case, there still was a loss. We can't eliminate all risks. I need to do it again. Let me take something to drink because my breath. Before I end, let me tie this back to the evidence. A recent large-scale study published in Medicina 2023 looked at over 50,000 pregnancies, including more than 2,000 with gestational diabetes. And their findings were while gestational diabetes increases the risk of complications like preterm birth, macrosomia, and NICU admission, it does not significantly raise the risk of stillbirth, not when care is managed properly in a multidisciplinary setting. The take-home message here is even with optimal care, gestational diabetes is complex. It requires more monitoring, more documentation, and often collaboration across specialties. This patient had all of that. The system worked as designed, and still it wasn't enough to prevent loss. We can't eliminate risk, but we can build systems that explain, support, and adapt. And that's what separates care from punishment. I wish this story had a different ending. I wish there had been one more clue, one more warning sign, something that would have made the doctor act earlier. But there wasn't. This was another episode of Doctors in Court, and thank you for staying with me. If you found this helpful, share it with a colleague and come back next week, because this isn't the last time a doctor will be called to account for something that wasn't their fault. And I'll see you in the next episode. The case of a missed syndrome. When patients keep calling and calling, you need to go deeper. Let me start with a sentence that might stick with you all day. A woman kept calling the out of hours GP line over and over and over again for 3 whole weeks. She said she couldn't breathe. She was weak, she was scared, and then she died. Today in Doctors in Court, we're diving into the case of a patient whose deterioration happened right in front of her doctors, and yet no one quite put the puzzle together until it was too late. It's May 13, 2009. That's when the patient first contacts the out of hours GP post. She's coughing, has a fever, she's weak, and she gets a home visit. The GP prescribes doxycycline and diagnoses a possible pneumonia. Over the next week, the calls keep coming. May 16th, she calls again. Still weak, still coughing. GP prescribes prednisolone. May 19th, another call. GP advises to continue prednisolone and rest. Same thing on May 22nd. Then May 23rd, this time she's vomiting. The doctor finally refers her to the ER. Labs are taken. The CRP is 19, hemoglobin 6.6, platelets are down, white blood count is low. She's admitted overnight, but the discharge says presumed viral infection. No one considers it a hematological disorder. From May 27 to June the 1st, she keeps calling. Still no improvement. On June the 2nd, she's admitted again. In the ICU this time. It's too late. On June 4th, she dies. What's her diagnosis? Myelodysplastic syndrome, a rare blood cancer that had been quietly destroying her bone marrow. So let's talk about myelodysplastic syndrome, or MDS. MDS isn't something you find easily. It mimics viral symptoms. It causes vague fatigue, shortness of breath, infections, and bruising. And unless you do blood work, good blood work, it doesn't show up. And the problem in this case, the blood work was done on May 23rd, and it showed pancytopenia. All the major blood lines were suppressed, and yet the referral letter said vague viral symptoms. The hospital didn't flag the labs as worrying, and the discharge went out without a follow-up plan for the blood values. Here's what we as clinicians need to look for when pancytopenia is even a remote possibility. Check the hemoglobin. Anything below the normal range is a First of all, check hemoglobin. Anything below the normal range in a symptomatic patient should raise concern. In this case, she was really low. White blood cells. Below the normal can mean infection or marrow suppression, and a low neutrophil count is particularly alarming. Check platelets. Normal range is normal. Check platelets. If a patient is under a certain value or under the norm, depending on your laboratory, and especially if symptomatic, that's a red flag. And anything under 50 always increases bleeding risk. MCV, mean corpuscular volume. High MCV may suggest marrow dysfunction, especially in MDS. Check the reticulocytes. Low count can indicate bone marrow isn't producing new blood cells. If all 3 cell lines are down, you have to go beyond viral infections. You need to think hematology. You have to think bone marrow biopsy. So what did the family think of the situation? Apart from being very angry, they were extremely upset, not just because their loved one died, but because they saw her trying to get help. She kept calling, and the GP kept saying, continue medication, give it time. And they said no one listened. She was deteriorating, she wasn't herself, and she was afraid. The father complained, accused the doctor of missing a life-threatening condition, of not acting on abnormal labs, of failing to coordinate follow-up care after discharge. The GP responded by saying, so what did the disciplinary board say? They acknowledged the complexity. They did not find a breach of care. The GP acted within the bounds of general practice. He documented his decisions, he referred appropriately, and the hospital did not communicate the lab findings directly. And while in hindsight, the signs of bone marrow failure was present, they were not obvious enough to constitute negligence. So what happened to the complaint? It was unfounded, case dismissed. Let's look at what the research says. According to a 2021 article in Blood Research, MDS is increasingly recognized as a genetic and environmental disease. Symptoms can be misleading. Fatigue, bleeding, infections, and diagnosis often depends on full blood counts and bone marrow biopsy. And here's the thing that can really cause a doctor to misdiagnose. Early signs of pancytopenia are often brushed off as viral or medication induced, especially in primary care. Now, the article stresses the need for clinicians to think hematologically when faced with multilineage cytopenia, especially in older adults. So yes, this was a rare case, but it was catchable. The warning signs were there, but no one saw the pattern. I want to leave you with a few questions to reflect on. How often do we disregard early abnormal labs when we trust the discharge summary? Unfortunately, it happens more than we think, and it's a system default. We trust the specialist, but labs are objective data. And if something looks off, it's okay to follow up. In fact, it's essential. Your gut feeling counts in this case. Another question: should GPs have direct access to inpatient lab results when they refer? I think they do. We need better interoperability. If we send a patient in and labs are drawn, we need a way to see those results in real time, not 3 days later or not ever. At what point does repeating symptoms become trigger for reevaluation and not reassurance? After the second or third call, especially if the symptoms evolve or escalate, this happens to me many times. If symptoms do not resolve and I see an escalation, I will take action. In this case, the vomiting, the weight loss, the ongoing fatigue, those were warning signs, not just persistence, but progression. And that's when we as doctors need to stop and ask ourselves, what have we missed? This is what I've taken home. Here's what this case has taught me: document, even if it feels redundant. Follow up on your gut. If the calls keep coming, look again, look deeper, talk to colleagues, ask for help. And hospital discharge doesn't always equal closure. Sometimes it's just the beginning. And finally, labs don't have emotions, but patients do. If someone is scared enough to call you multiple times, that's a symptom also. Do not ignore that. Thank you for joining me and the doctors in court. One patient, one story, real cases. It's also a lesson in listening. See you next week. Guys, thank you so much for joining. If you like this, subscribe and share it with a colleague. One case at a time, we can make a difference. This is Doctors in Court, and this episode is about power, perception, and the fine print of privacy. Let's rewind to October 2009. The patient, who I'll call Mr. Lamas, has been sick and he's on sick leave. He's been assessed by an insurance doctor for ongoing disability support. His GP, I'll call her Dr. Kamal, has been treating him for chronic fatigue and adjustment disorder. There have been letters back and forth with the insurance system, but no formal consent for medical exchange. On October 28th, the insurance doctor, I'll call Dr. Smith, receives a medical file by fax. It's from the company doctor involved in the case. The fax contains detailed patient information, includes psychiatric reports and treatment plans. Dr. Smith reads the fax. He uses the information to assess the claimant's status, but the patient says, I never gave permission for that. That information was sent without my consent and you used it. A complaint is filed with the regional disciplinary board in a city called Utrecht in the Netherlands. Now, Mr. Lammers, the patient, argues the following. He never signed a release form authorizing the transfer of medical data. He had explicitly said he didn't want psychological information shared with the insurance doctor. The insurance doctor should have sent the fax back unopened or destroyed it. And by using this information, the doctor violated his privacy and the law protecting patient data, the Dutch Personal Data Protection Act. His GP, Dr. Kamal, supported his complaint, saying she had never consented for this information to be forwarded either. So let's take a look at what Dr. Smith said. Dr. Smith argued that he did not request the file, it arrived spontaneously from the company physician. Once he received it, he had a duty to assess its relevance, especially if it related to public benefit. He didn't share the data or disseminate it further. And he followed internal insurance medical procedures for handling unsolicited data. In his professional opinion, refusing to read incoming clinical information could be medically irresponsible. He maintained that his actions were reasonable given the context of social insurance medicine. Let's talk about what this means in practice. In the Netherlands, patients' privacy is protected under the Dutch Personal Data Protection Act. Medical data is extra sensitive. Even within care and insurance systems, doctors need explicit patient consent before sharing or using medical records unless there's a legal basis to override that. Unsolicited data, and that's tricky. The law doesn't say you must read it, but it also doesn't clearly say that you must destroy it either. The expectation is stop, verify, document. But that's not always how it plays out in real life. The disciplinary board in Utrecht considered the arguments on both sides, and here's what they ruled. The insurance doctor did not act in violation of medical ethical standards. The board found no evidence that the doctor actively solicited the medical information. Once received, the information was used within the limited scope of his role and not shared any further. However, the board reminded all doctors that handling medical data, even unsolicited, requires strict awareness of consent boundaries. And the result of this complaint was unfounded. There was no warning, there was no reprimand. Before I leave, let's put in some evidence. A 2022 review published in Clinical Rehabilitation explored how fitness for work evaluations often lead to overreach, even when unintentional. The paper argued that vague boundaries between the therapeutic roles like the GP or psychologist and evaluative ones like insurance or occupational health can lead to ethical friction. It highlighted three key risks: involuntary disclosure, where patients lose control over their data. It also highlights dual loyalty conflict when doctors serve two masters, the system and the patient. The last thing it highlights is scope creep, where medical documents are used for purposes far beyond their original intent. The article concluded that the solution lies not only in law, but in culture. There needs to be clearer communication, stricter gatekeeping, and always patient centered transparency. Let me ask you a few questions. If a fax with medical data lands on your desk without consent, should you read it? Honestly, it depends, but the safest route is to stop, document its arrival, notify your superior or privacy officer, and do not use it until consent is verified. Reading it may seem harmless, but it opens the door to unintended ethical breaches. Another question I want to ask you is it fair to expect insurance doctors to not use relevant data when it's dropped in their lap? It's understandable to want to use what you're given, but fairness isn't the same as legality. If you use data obtained without consent, you're putting yourself and your patient's trust at risk. The question isn't whether it's useful, it's whether it's yours to use. And the last question: what system fixes could prevent this? We need stronger digital barriers, no more faxes, clearer referral protocols, shared platforms where data. What I think we need are stronger digital barriers, no more faxes. That's just outdated. Clearer referral protocols are also needed, shared platforms where data access is consent driven, traceable, and patient approved. Also, ongoing training for insurance doctors on boundary management. So, here's what I'm walking away with from this case. If it's not your data, don't assume you're allowed to use it. And privacy isn't a checkbox, it's a culture. And when in doubt, document, pause, and ask yourself, because one well intentioned moment of curiosity can turn into a disciplinary hearing. We all want to help, we all want full information, but in social medicine, the lines are blurry and the consequences are sharp. You don't have to be wrong to end up in court, you just have to be unguarded. This was Doctors in Court. Subscribe, share with a colleague, and I'll see you next week for another story that proves medicine is never just clinical. But again, stay curious and stay careful. This case is about the novice doctor and the report the novice doctor wrote. Welcome to another case of Doctors in Court, where we're going to talk about the novice doctor and their report. Let me ask you this. If you recently graduated as a doctor and you're working under supervision and you issued a medical opinion based on written records, is that enough? What if you never saw the patient face to face? Welcome back to Doctors in Court. Today's story is about trust, not just between doctor and patient, but between a trainee and their supervisor. And it starts with a function report, no physical exam, and it ends with a complaint. A lesson in what it really means to be a doctor in training in the field. In 2009, a young physician, let's call her Dr. Noah, is working as a company doctor in training. She's been asked to complete a functional assessment form for work disability purposes. And the patient in this case, I'll call him Mr. Johnson, is someone with complex complaints, long medical history, neurological symptoms, psychological factors play a role, and Dr. Noah never physically examined Mr. Johnson. Instead, she reviews his files. A specialist reports a colleague's prior notes, and under supervision, she drafts the functional medical assessment and files it. A few weeks later, a complaint lands on her desk. Mr. Johnson is furious. And why is he furious? Well, why is he furious? Well, Mr. Youngson argues that Dr. Noah never examined him. She made medical conclusions she made medical conclusions based solely on paper. She ignored his treating specialist's opinions, and she worked outside her authority as a trainee doctor. He never agreed to this process at all. In his eyes, this was not only unprofessional, it was unethical. Dr. Noah replies, she was working under the supervision of a company physician. She used detailed existing records and made no new diagnosis. And the functional medical assessment form was based on documented findings and not on speculation. The patient has signed an insurance consent form allowing data use, and she was not acting independently, but as part of a supervised protocol. And her supervisor confirmed all of this. Let's talk a little bit about a functional medical assessment. It's a form used in the Netherlands to determine what somebody can do functionally in the context of work, not necessarily to make or confirm a diagnosis. It often relies on a few things such as medical reports, employee feedback, and prior assessments. And while physical examination is preferred, it's not always required, especially if there's adequate recent data already on file. Also worth noting, being a trainee doctor in the Netherlands doesn't mean you can't contribute, it means you do so with supervision. So the disciplinary board looked closely at all their claims, and they found there was no evidence of negligence. There was no evidence of privacy breach. The patient had consented prior to data use, and there was no overstepping. The doctor stayed within the boundaries of a doctor in training. There was also no evidence of disregard of specialist input. Her conclusions were in line with documented opinions. And the key here is that she worked under supervision and followed protocol. The verdict for this complaint is dismissed and no action was taken. To give this some depth, I want to bring in Patricia Benner's classic framework from novice to expert. Now, Benner describes how clinical wisdom develops over time, from rule-based decision-making in new graduates to intuitive judgment in experienced professionals. In her model, novices rely on guidelines, documentation, and external validation. Advanced beginners start linking patient data with context. Competent clinicians can prioritize and synthesize on their own. Dr. Noah was right where she should have been, reviewing charts, following structure, checking in with her supervisor. And the lesson here isn't that she should have known more, it's that she operated safely within her stage of growth, and that matters just as much as the outcome. Let me leave you with a few questions to reflect on. Can you make a responsible clinical judgment without ever being near the patient or even seeing the patient? Sometimes you can, actually, especially in systems like insurance medicine where structured documentation is central. But again, transparency is key with your supervisor and with the patient if possible. Another question to reflect on: what is the role of supervision in protecting early career doctors? Supervision isn't just a formality, it's a safety net for the doctor, the patient, and the system. And it's our job as seniors to make sure our juniors know how to fall safely when things get hard. How do we balance respect for experience with room for growth? Well, we need both experience and growth. Patients deserve quality of care, but junior doctors deserve space to learn, given the boundaries, given good mentorship and reflection. One without the other breeds fear. Both together build clinicians with depth. So here's what I'm walking away with from this case. Don't confuse inexperience with incompetence. Trusting the system means trusting supervision, and most of all, clinical work is more than just doing. It's thinking, documenting, and communicating clearly. This complaint didn't stick, but it gave us all a moment to pause and ask, how do we prepare our new doctors for the real world without exposing them to legal fire? This was another Doctors in Court. One junior doctor, one complaint, and a system that worked. Not because she was perfect, but because she was supported. If this spoke to you, whether you're early in your career or guiding someone who is, share it, subscribe, and join me again for another real life case. Because accountability isn't about punishment, it's about learning. Until next time.